Thank you guys for joining me for Chapter 4 review of the skeletal system. This is what we're going to be looking at mostly when we're doing our radiographic images. So some of these pathologies are what you're going to come across most frequently. So we'll get started here. I'll go ahead and have you read through the chapter objectives. Take a moment to make sure that you're looking for these things as you go through your reading and listen to our lecture today. Now, our bone does have a covering on it, and that covering that goes around the bone on the outer surface is called the periosteum. The periosteum is going to cover the entire shaft or diaphysis of the bone, except for here at the articular ends where they're going to articulate with another bone. At these articular ends, the bone is covered by an articular cartilage rather than the periosteum. Within that periosteum, which is just external to the cortex, runs a lot of our vessels and nerves that are going to help to provide nutrients and oxygens to our bone for growth. Now, inside of the bone, in this medullary shaft here, it is also lined with a lining, and that is called our endosteum. And that endosteum is going to cover this internal open shaft. Again, that's where our bone marrow is going to be housed for that production of our red blood cells. Now, over time, our bones don't just grow in length, like I just described by use of those epiphyseal plates, but they also have to grow in diameter. So one of the ways that these grow in diameter is that it consists of two types of bone cells that assist in this process. The first type is an osteoclast, and our osteoclasts are really important. They're actually going to be breaking down bone. So as our bones grow, the osteoclasts break down the central portion of the bone and kind of help hollow out this medullary cavity. Our osteoblasts, on the other hand, build up the bone on the outer layers. So our bone is becoming more hollow in the center, but it's building up thicker and becoming broader to become the bones that we need in adulthood. So we're really dependent on our osteoclasts and our osteoblasts working together to build out that bone while our cartilage builds and ossifies on the ends of the bone, allowing them for them to grow in length. Now, over time, these osteoclasts and osteoblasts, even after the bones are done forming, will continue their process of breaking down and regenerating bone until we're in our 40s or so. And at that point, the osteoblasts really aren't able to keep up with the osteoclasts as well. And so we find that's about the age that our bones may start to deteriorate a little bit and not be building up and maintaining the density that we once had. That brings us to our first group of pathologies that we find in our skeletal system, and these are known as congenital or hereditary diseases of the bone. So these are either a disease that the child is born with and always exists in that person, or it's a hereditary disease where they will have genetic components for this disease. So it will also be something that they're born with, but it's also tied to their genetic makeup. Some of these anomalies are going to be your vertebral anomalies, Spina Bifida, Osteopetrosis, Osteogenesis Imperfecta, Achondroplasia, and congenital hip dysplasia. If we look at our vertebral anomalies, we can, when we see the term anomaly versus abnormality, we know that anomalies aren't typically going to cause our patients a lot of problems. They're mostly going to be an incidental finding. Although they can have some mild effects, they're usually not extreme enough to classify them as an abnormality. So one of our vertebral anomalies is our transitional vertebra. And we know that we have transitional vertebra, like our C7 is considered a transitional vertebra. It doesn't have entirely cervical characteristics, but it doesn't necessarily have entirely thoracic characteristics either. It lies in the middle somewhere. We see the same thing when we transition from our thoracic to our lumbar spine. Our L1 can often take on some characteristics of our thoracic spine. So some of the things you might see here in a transitional vertebra anomaly is rudimentary ribs growing off of or articulating with C7, or rudimentary ribs again articulating with L1. the lumbar and the cervical spine should not have ribs, but these transitional vertebrae sometimes demonstrate some of those qualities of the adjacent part of the spine. These can occasionally cause issues, especially the cervical ribs, in that you have a lot of nerves going through that area, and so sometimes they can cause compression on nerves and cause some shoulder or arm, hand issues with numbness. Our next defect is Spina Bifida. Now, Spina Bifida has a number of different forms, some of them that can be relatively benign and some that can cause some significant problems for a person with this problem. So Spina Bifida is a spinal canal defect caused from a failure of the posterior elements to fuse properly. This is not genetically linked, and usually the use of folic acid prior to the prenatal period and within the prenatal period will help to prevent the spina bifida, which is also known as an open neural tube defect. Spina bifida occulta, which is the image we see here onto the right, is very mild and often found only as an incidental finding. What we see with spina bifida occulta is that there's a splitting of the neural canal at L5-S1 levels. So you see right here that the lamina here are not fully fused, having a good spinal, a good vertebral spinous process in the back, and that can allow it, and it's just a mild defect. Typically with this, your spinal cord is contained still within the intervertebral foramen, and it won't cause any issues for the patient, but it is an incidental finding that should be noted. One of the other things that you can see with this, even if the patient has no other issues, is they may have a dimple and a tuft of hair on their external sacral area right at this level, and that's indicative of spina bifida occulta. Now, as these defects get more significant, they get classified either as meningoceles or myelomeningioceles. Now, a meningiocele is, if we remember what our spinal cord is made of, we have a few different layers of our spinal cord, and the outermost layer is our meninges. And so if this is significant enough that our meninges begin to protrude outside of this defect, then we would have a meningiocele. These are typically or often incidental findings as well. The patient may not have no symptoms, but if they are large enough, you can notice some defects in the patient's abilities to move and move spinal fluid through their spinal column. Now, myelomeningioceles is the most significant, and with the myelomeningioceles, not only do you have the meninges, or that outer membrane of the spinal cord, but you also have the actual spinal cord itself herniating out of this defect. Now, the defect doesn't only happen at one level. As you get to these larger defects, they're going to happen at multi-levels. The level that it happens at is usually the level that these patients start experiencing neurologic deficit. So the higher this is in the spinal column, the more effects the patient will demonstrate. And some of the effects they may demonstrate is an inability to control their bladder, an inability to weight bear, many different nervous activities that they require their nervous system for, they would notice some deficit in. So here's an example of a larger defect at, this is a transitional vertebra at the L5-S1 junction. So sorry, I slipped this one in the wrong place. One other thing these meningomyelocele are connected with, or often demonstrate, is a correlation with Arnold-Chiari syndrome. And what Arnold-Chiari syndrome is it's the protrusion of the lower brain out the foramen of the skull. And so because you kind of think about this like ringing a bell, if the spinal cord is supposed to come straight down the spine and then diverge and create this cauda equina and that sort of thing. It should be nice and taut from top to bottom. But as we have these meningomyelocele, that tight cord is then being tugged out the back of the person. And when that happens, it's actually it being attached to the brain is actually going to pull the brain down and cause it to herniate out of the foramen of the cranium. Because of that, the cerebellum gets squished and partially herniated out to different degrees, and it can cause some deficit with some brain components as well. Our next disease is called osteopetrosis, and this is not to be confused with osteoporosis. Osteopetrosis is known as marble bones. It's a rare hereditary disease, so it's linked to our genetics. And what occurs with this is there's a dysplasia in which the failure of the resorption mechanism of the calcified cartilage interferes with normal bone replacement. So usually we talked about the osteoblasts and the osteoclasts, and they're working together, and those osteoclasts are breaking down bone while the osteoblasts build it up. And with osteoporosis, it doesn't do this correctly. The balance is off. And so those osteoclasts are not breaking down that bone, and the osteoblasts just keep piling it up. So you see it become very thick and attenuative. Now you might think that that would make very strong bones, but it actually works in the reverse. So as those bones continue building up, they become more and more brittle and more likely to have a fracture. So with these patients, you would have to adjust your techniques significantly to get adequate penetration to evaluate the bones. You notice a lack of trabecular pattern here, and that's because you're just not getting the penetration to get through the bones. Obviously, if you were able to make this look like a somewhat normal x-ray, you would want to note that you had to use extremely high technique to accomplish that. So that's going to be your osteopetrosis. There are some different treatment options, such as stem cells and bone marrow transplants and things like that. One of the other things that happens is we talked about how our osteoclasts clean out that medullary cavity, which provides room for the bone marrow to live, and that bone marrow is in charge of producing red blood cells. If these osteoclasts don't break down that medullary cavity, the bone marrow can't live there normally, and we'll see a reduction in the red blood counts of these patients because they're not creating as many red blood cells as they're intended to. Here's just an image of an osteopetrosis hand, and you'll certainly notice that there's a lack of that trabecular pattern that we're so used to seeing. Our next hereditary disease is Osteogenesis Imperfecta, and this is often called brittle bone disease. This is another abnormality that is linked to your genetics. So this is something that you're born with. What happens here is it's a connective tissue characterized by a connective tissue disorder characterized by multiple fractures and an unusual blue color in the sclera of the eye. So instead of having that white background to your eyes, they can look a little bit blue. And this affects your bone's ability to build up and calcify your cartilages. So with this, cartilages develop, but they don't become fully calcified, and so the bones remain very weak, and they can have lots of fractures. There's a few different types of osteogenesis imperfecta. The one that we look at the most is the most significant. So you would see this baby, he has had multiple fractures. This is obviously a newborn, and you can see these multiple fractures, and the osteoblasts try to repair these fractures, and they'll almost cause a mass-like appearance in their regeneration. Lots of times these babies are fractured when they're born. If they've had a lesser case of this and they're coming in maybe in childhood and demonstrating multiple fractures, some people may mistake this for a child abuse case. So they would have to be genetically followed up to determine if it was osteogenesis imperfecta or child abuse. But you can even see this little baby's ribs are ribs are fractured up here, multiple fractures of the femurs. When they're correcting themselves or trying to regenerate, they're regenerating at unusual angles. And so this is a very significant disease. Our next kind of congenital disease is achondroplasia. And this again is linked to hereditary, linked to our genes, so it is hereditary. Achondroplasia is a type of dwarfism, and there's many different types of dwarfism. Lots of them are not compatible with life, meaning that the person cannot live with this abnormality. However, achondroplasia is one of the most normal cases of dwarfism where they can go on to lead pretty normal lives. The achondroplasia, how the process works is it results from a diminished proliferation of cartilage in those long bones, especially at the growth plate. So usually, as we talked about the development of the length of the bones, we saw that epiphyseal plate created cartilage, and then that cartilage was ossified, and in turn the bone grew longer and longer. With achondroplasia, that cartilage does not grow, so there's nothing there to be ossified, and the bones just stay very short. This is an autosomal dominant condition, so it is linked to the genes. It's characterized by short limbs and a normal axial skeleton. And we talk about axial skeleton, we're meaning like the thoracic and abdominal area. So these people will have a normal stature from shoulders to, say, pelvis, but their arms, legs, all their long bones are going to be quite shortened. Most of people with achondroplasia can go on and live relatively normal lives, especially with today's technology. There are some treatments that they're now trying to do surgical treatments to lengthen those long bones. When you see somebody with this, you might often think that they have a little bit of lordosis of their spine, and that comes from a prominent buttocks. The achondroplasia also will not affect their skull development. So their skull bones will continue to develop at a normal pace. So they may look like they have a big head compared to the rest of their body. They can have a prominent forehead and demonstrate that appearance. Now, some babies are born with congenital hip dysplasia. This is a congenital problem, so it's something they're born with. It is not linked to heredity, so it is not a problem with the genes. So with congenital hip dysplasia, what happens is the acetabulum of the pelvis underdevelops, and so with any movement of the affected hip, the femur will pop out of socket. And so how this can be diagnosed is when you do a cleaves or a frog leg exam of the pelvis. You can see on this image on our right that the baby's left femur seems relatively in place, but if we look at the right femur, you can see that it is significantly dislocated here. Another way that you can do this is by looking at ultrasound. So because these children will often need a lot of follow-up for these exams, it takes radiation, or a cumulative amount of radiation over time builds up. So ultrasound is a very good approach to evaluating for congenital hip dysplasia. However, you have to have somebody that has some experience with this to complete the exam, and radiologists that are comfortable reading the exams, because they have to do very specific measurements of angles from the femur to the pelvis, and there's not a lot of experts in this area out there. So being able to get that exam done sonographically could depend on your location. Now, one of the reasons this happens is often because if a baby in utero has an inadequate amount of fluid surrounding them, there will be compression on the hip and it won't be able to grow naturally. Another factor is physiologic, where the baby is exposed to increased hormones around delivery. So there's a couple different things that can feed into this. One of the treatments is basically to immobilize the leg, trying to give the acetabulum more time to grow, and they do this by doing a pelvic and femoral cast. So here we have just a brief summary of what we talked about today. So you can take a look through these, make sure that you're taking note of some of the most important qualities of each of these abnormalities so that you can identify them on your radiographs. Okay, review question. What complication is associated with spina bifida? A myelomeningocele, a herniated disc, scoliosis, or there's no complications? You should have answered A myelomeningocele. With spina bifida, we have a defect in the bony closure of the spinal column. And so when we have that defect, it can allow for the meninges and the spinal cord to herniate out, which would cause significant complications. Review question 2. Which hereditary disease is characterized by brittle bones and frequent fractures? We know that Osteopetrosis has brittle bones, but it's actually known as marble bone, and they are extremely dense. And so our best answer here is going to be Osteogenesis Imperfecta. And that brings us to our inflammatory and infectious disorders. So we're going to look at rheumatoid arthritis, osteoarthritis, infective arthritis, tuberculosis arthritis, bursitis, rotator cuff tears, tears of the menisci of the knee, bacterial osteomyelitis, and tuberculous osteomyelitis. So rheumatoid arthritis is a process that can have very significant effects on the patients. This is an idiopathic disease, meaning we don't fully understand how or why it starts. It is considered an autoimmune disease where the immunities of our body attack our own body parts, and it tends to be chronic. It usually appears primarily as a non-infectious inflammatory reaction within synovial joints. So any of your joints that have synovial articulations are going to demonstrate or could demonstrate rheumatoid arthritis first. Most often, rheumatoid arthritis is noted in the hands initially. And one of the things that happens with rheumatoid arthritis is the inflammation begins in that synovial joint space. And as it does this, it creates an altered metabolism in that area, and it fibroses in a way. And as that fibrotic type tissue sits over the joint space, it can actually cause degeneration of the bone itself. And as that bone degenerates, you'll note, as we see in this image here, that you see osteoporosis at the distal bones as they near the joint. Over time, these joints can then sublux, and if they start to attempt to heal, they can actually fuse the two joints in a process called ankylosing. So when two joints become fused, they're ankylosed, and it's one solid bone. As I said, this can usually start in the hands. You'll notice it progress through other other joints as well. Most of the joints do maintain somewhat smooth borders, so this is not the arthritis where you see that spurring and lipping at the joint spaces. This is from the inflammatory process, degenerating the joint, degenerating the ends of the bone, and then causing rebuilding patterns. It can be debilitating. It's usually treated with NSAIDs. There are some different medication approaches that are intended to slow the progression of the disease. It is more common in women and usually appears in around their 40s. There is a form called juvenile arthritis that is a little less significant but typically appears earlier in life. With rheumatoid arthritis, there can actually be a number of different variants. So if this rheumatoid arthritis process starts to affect the spine, what we can often see is ankylosing spondylitis. And what happens here is the same sort of idea. Inflammation will occur in the joint spaces. That inflammation will produce some fibrous type tissue. That tissue will degenerate the bone itself, and then as regeneration occurs, you'll see that the bones can fuse together. Therefore, we call this ankylosing because that's the fusion across the joints. space, and then spondylitis, inflammation of the spine. A nickname for this is called bamboo spine. So you'll see this continuous bony cortex all the way up the spine with no gaps here at the disc space. This really decreases the patient's ability to move, so they often see a lot of bony degeneration with this and have osteoporosis and are more likely to have fractures and that type of thing. This usually starts at the sacral level and moves its way up the spine. Now, osteoarthritis is different than our rheumatoid arthritis. Osteoarthritis typically affects weight-bearing joints, whether they're synovial joints or not. It's not commonly affecting just the hands or just your synovial joints. It's really going to affect things like the knees and the hips and the parts of the body that carry the most weight. It is something that we do see in fingers, probably because of overuse. Sometimes if you've had a chronic injury to a certain body part, that joint would be then more likely to have osteoarthritis. Now, with rheumatoid arthritis, it usually affects the body fairly symmetrically, so you'd have both hands affected, you'd have both knees affected. With osteoarthritis, it can actually affect things asymmetrically. So if I'm right-handed and my right hand has done most of the work over my life, then I probably get osteoarthritis in my right hand first. It's generally considered part of the wear and tear process. Now, this osteoarthritis is the one that we do notice that lipping and spurring on. So when you start seeing these roughening of the cortical edges, that's going to be osteoarthritis, more of the wear and tear process than an autoimmune response. You often also see joint narrowing with this disease at different levels. So you can see here, one side of the joint is almost nearly closed while the other joint remains open. It can make this really frustrating when you're trying to get a knee on a patient like this. So realize some of that is going to be due to their osteoarthritis, or also known as degenerative joint disease, and it's not you failing at your imaging. Infectious arthritis is usually caused by the introduction of some sort of pyogenic organism. And a pyogenic organism is a pus-producing organism. And so that organism can get into the joint space, and then it will basically attack the articular cartilage. And so the first thing that you see here is some effusion in the joint, and then you see a breaking down of that articular cartilage. Oftentimes, this would be from some kind of trauma or recent instrumentation, like a shoulder surgery or something like this. If it's not from trauma or surgery, the other most common type is a migratory arthritis disease like Lyme disease. And so what happens here is that there's an infection inside the body, and that infection travels through the bloodstream and settles into one of your joints. And that's when you would have infectious arthritis in that joint. Now, the good news about this is if it's identified early enough, then they can treat these infectious arthritis with antibiotics or antivirals or something to attack the infection. It's not just an arthritis that's going to progress over time. Tuberculosis arthritis, you guys know from our tuberculosis talk during the respiratory lecture that tuberculosis really starts in the lungs, but it can settle in other organs as well. And so one of the places it can settle is in a joint. And one of the things we typically notice about tuberculosis arthritis is it's inflammation in a joint, and it's usually asymmetric again. So it's usually going to be one elbow, as in this case, not both. Usually the infection has had to run rampant for quite some time before it to cause tuberculosis arthritis. So you'll find active tubercles typically elsewhere in the body along with the tuberculosis arthritis. The early appearance of this is similar to the infective arthritis, where you get a disruption of that articular lining or articular cartilage, and that's going to be the first sign of a problem. It usually involves the spine, hip, knees, or as in this case, the elbow. And it would be treated with anti-tuberculin drugs and NSAIDs to reduce the pain. That brings us to bursitis. And you remember that bursa, this was from RAD 116, is that bursa are basically little pouches of fluids that are typically around joint spaces, and they're basically there to protect the friction of that joint space. So it's not within the joint space itself, but it's external to the joint space, and it can provide some padding to that area of the body. And bursitis occurs, as the name says, when there's inflammation, itis, of the bursa. So inflammation of the bursa can be very painful, and it's not often well visualized on radiography. So lots of times there's actually, you have to look in sonography, you can find that bursa, which would be a fluid-filled sac, and if it looked enlarged and it had a lot of blood flow, also known as hyperemia, then that could be indicative of bursitis. Now, because it's an inflammation, this would be treated with an anti-inflammatory, so an NSAID, a non-steroidal anti-inflammatory drug. Most commonly, these are caused by repeated physical activity. So it might be somebody that's, plays tennis, that is frequently always swinging their tennis racket. They might get a bursitis of the shoulder. It can be caused by trauma, inflammation due to rheumatoid arthritis, gout, which would be an accumulation of uric acid, or other types of infections. But again, it's a relatively easy treatment and diagnosis. Now, one thing you might find on an x-ray is an indication that bursitis was there, because sometimes a patient that has bursitis will develop calcifications of the tendons near the inflamed bursa. So sometimes you'll see those calcified tendons rather than the bursitis itself, and that would be an indicator that bursitis had affected that area. Rotator cuff tears are a common shoulder injury. So the rotator cuff consists of some of the muscles of the superior shoulder. And what happens when these muscles, the teres minor, infraspinatus, supraspinatus, and subcapsularis muscle, if there's a rupture of that rotator cuff formed by these muscles, the fluid will begin to communicate with the fluid of the shoulder bursa. So of the subacromial area. So these can be difficult to see in radiography, so they're typically evaluated for MRI. There is beginning to be some movement toward utilizing ultrasound for these, although musculoskeletal ultrasound is a newer modality and not available everywhere. Some of the treatments for the rotator cuff tears would be for bracing or inactivity, rest, and taking anti-inflammatories. If that is not creating the desired results, then often an orthopedic surgeon would go in and do a surgery for the rotator cuff. As you remember from RAD 116, the meniscus, or the menisci for plural, are the pads that settle in between the tibial plateau and the femoral condyles. And just because of the natural nature of the knee and knee movement, it can be relatively common to have a tear in the meniscus. If the tear in the meniscus, it can be caused by acute trauma, but more often than not, it's due to degeneration or the chronic trauma or use of that knee. And you see in our image here, this is actually an MRI. The general radiography is not going to be the best approach to evaluating the meniscus, but an MRI will typically be utilized to make this diagnosis. Again, sometimes rest and anti-inflammatories are enough to help, but if there is enough meniscus still available for repair, then this can again be repaired through orthopedic surgery. Osteomyelitis is going to be inflammation of the bone, And so inflammation of the bone can be very, very dangerous. So the most common type of osteomyelitis is your bacterial osteomyelitis. And this will usually happen from inflammation of the bone and marrow caused by a variety of infectious agents. And those agents can be introduced to the bone a number of different ways. One of the common ways is through hematogenous spread, and that means spread through the bloodstream. And when a bacterial osteomyelitis is spread through the bloodstream, it typically goes to where there's the most bone marrow present. So in children, this would be in their fibula area. And so often in children, you'll find bacterial osteomyelitis there. In adults, we know that our spine is where we produce most of our red blood cells. That's where our highest levels of marrow are, in our spine and hips. And so that's where most adults are going to demonstrate bacterial osteomyelitis. Now, these infectious organisms, they get into the joint and they can typically start inflaming the joint and get underneath the periosteum. And once they're underneath that periosteum, that inflammation can spread down the joint or down the bone itself. As the inflammation occurs, it can disrupt the blood supply and that disruption can cause some necrosis of the bone along with that bacterial infection. So these bone inflammation can snowball very quickly and turn from a small inflammation to a huge problem in limited amount of time. Radiography is not going to be good at picking up osteomyelitis in the first 10 days of the symptom onset. After about 10 days, they can start seeing some necrotic changes in the bone, along with that periosteum being separated from the lower layers of the bone. In addition, with these patients, you're going to see that they have, because it's an infective and inflammatory process, you're going to have an elevated white blood count, a lot of pain, heat at the site, and often fever. If they've had a direct introduction, what I talked about already was the introduction of the bacteria through hematogenous spread. So the infection was in the body and it spread, and those are the osteomyelitis that are usually going to occur where the bone marrow is most densely located. Other spreads could be from direct infection. So if you had a bad infection some part of the body and it was able to migrate into that bone, that could cause osteomyelitis. Surgery to the area and direct trauma to that area could also cause it. This is best diagnosed early on, since radiography can't see it for about 10 days. It's best diagnosed early on with nuclear med studies. Now, typically the acute response will be significant, and these patients would get treatment for probably 4 to 6 to 8 weeks. But sometimes if they're not treated properly, the inflammation can become dormant and then have reoccurrences. And those reoccurrences are going to be very difficult to identify because they'll have a similar appearance, or you won't know what was from the old osteomyelitis and what's from the new one. So again, that's where nuclear medicine comes in as a good diagnostic tool for this. Now, sometimes a tuberculosis infection can cause osteomyelitis, and when that happens, we call it Pott's disease. This is really rare today just because tuberculosis numbers are so low, but it usually affects the mid-thoracic to upper lumbar spine if it does. It acts very similarly to the bacterial osteomyelitis, except that it doesn't elevate that periosteum layer. And in fact, it starts typically in the anterior spine, and it will basically break down that trabecular pattern in the spine itself, causing it to collapse on itself in sort of a wedge-shaped pattern that's indicative of Pott's disease. So here you're seeing osteomyelitis of the radius, and you're able to detect with these black arrows just where that periosteum is being elevated from the bone itself. That's going to be indicative of that infection or inflammation moving down the bone. You're also seeing some necrosis here due to disruption of the blood supply, and necrosis likely due to some of the bacterial attack. So here's a quick review of your inflammatory and infectious disorders. Okay, review question. Which modality is most commonly used to demonstrate soft tissue tears in the knee and shoulder? While we do use ultrasound, MRI is probably more readily available and unfortunately more expensive, but our answer should be C, MRI. Degenerative joint disease is more formally known as osteoarthritis. This is our common degenerative joint disease that we'll see in a number of our older patients. And this one is unique because it has that spurring and lipping and is from overuse of the joints. It usually affects those weight-bearing joints first. That brings us to metabolic bone disease. So in this group of diseases, we have osteoporosis, osteomyelitis, Rickets, gout, and Paget's disease. Our first kind of metabolic bone disease we're going to talk about is osteoporosis, and this is a very common disease, and you guys have probably seen this a lot in your patients already. So osteoporosis is the generalized or localized deficiency of the bone matrix in which the mass of the bone per unit volume is decreased in amount but normal in composition. So with osteoporosis, we're maintaining that same trabecular pattern, that same bony cortex, but it's just thinning it out. And so a lower level of osteoporosis is called osteopenia. So with mild thinning, they'll be classified as osteopenia. Once the thinning is significant, then it moves into the category of osteoporosis. Now, what causes osteoporosis is a combination of multiple factors. So often advanced age, as we advance in our age, our lytic processes of our bone structuring are more active than our building processes of those osteoclasts. So the osteoclasts are more active than our osteoblasts. So naturally, the body's trying to break down the bone a little bit faster than it would build it back up. Secondly, lots of times in our elderly years, we become a little bit less active, and that decrease in activity can lead to osteoporosis. Thirdly, especially in women, when you become postmenopausal, your body stops producing estrogen. So the farther away from menopause you are, the more years that you have not had as much estrogen as your body was used to. And estrogen is a component that helps maintain bone density. So as you remove that, you lose some bone density. Women are more commonly affected with osteoporosis, especially at an earlier time in their lives. Women that are very small in stature are at higher risk. Women who have had less estrogen exposure throughout their lives are higher at risk and can suffer more from this. So one of the problems with osteoporosis, it makes these patients much more likely to have fractures, even from very small traumatic events. And while a fracture may seem like something we can just fix and move on, there's actually a large mortality rate with something like a hip fracture can have very high rates as being that sentinel event that turned the patient's life around and sent them on the trajectory that led to their death. So this is a very significant disease. We are usually radiographers have a large role in diagnosing osteoporosis, as you can do a DEXA exam where you evaluate their lower spine and one hip and evaluate their bone density, and that should be done on a yearly basis to watch for any changes. Some of the things that can help improve bone density would be certain drugs that help decrease the lytic response of those cells, allowing time for the osteoblasts to build up more bone without it being broke down. Another approach is to give those postmenopausal females hormone replacement therapy, although the caveat with this is that that estrogen therapy can increase your risk for breast and ovarian and uterine cancer, so it comes with a risk as well. So for these patients, what you'll see on your radiographs is an overall decrease in bone density. So you'll be using a lower KVP possibly a lower overall technique, and you'll still be penetrating right through this bone. By the time you start seeing these significant penetration changes on your x-rays, the person has gone through at least 50 to 75% bone loss by that point. The other thing that you'll notice with these patients is that because the trabecular patterns of their bones are becoming so much more radiolucent, it almost makes the cortex look more bright or radio opaque, and that's just because of the contrast between how the center of the bone is breaking down versus how the cortex is breaking down. Now, osteomalacia, this is the breaking down of bone due to insufficient mineralization. So we know that that bones need to be mineralized, and we have to present calcium to the bones in order for them to grow and maintain. So osteomalacia occurs only in adult skeletons, and it can be caused by an inadequate intake or absorption of calcium. So there's not enough mineral there to put toward the bone, or phosphorus, which is a secondary mineral salt that's used in the bone matrix, or it could be a lack of vitamin D. And when we are low on vitamin D, it decreases the ability to absorb calcium through our gut. So if we don't have that vitamin D, we might be introducing enough calcium, but we're not absorbing it. So that can be another cause of osteomalacia. The appearance of osteomalacia is going to be relatively similar to that of osteoporosis. One of the other things that can be noted with osteomalacia is you might have normal calcium, you might have normal phosphorus and vitamin D, but if you're in kidney failure, you're not able to absorb those as well. So again, it can be caused by the lack of intake of these items, or it can be caused the inability to absorb them. Rickets is a similar disease to osteomalacia, but this actually occurs in children. And this disease is due to a lack of vitamin D. And so lots of times with babies, they'll appear jaundiced because they have a deficiency in vitamin D. And it can be caused by a lack of vitamin D due to the intake or their diet, or because they are not receiving enough ultraviolet exposure or sunshine, which allows them to convert that vitamin D to make it useful. Now, with rickets, these children will have, they'll have the cartilage at the end of their bones will continue to grow, but they won't have the ability to calcify that cartilage. And so what happens is you see their bones begin to bend because they're not ossifying the bone as they build them. And so the ligaments and tendons begin to bend those bones. And it's really common, especially in the tib-fib area. Here's an example of rickets where you're seeing this cupping that is unique to rickets. So you can see that the epiphyseal cartilage has continued to grow, and yet it has not been calcified. So this then goes and begins to bend over as you see it. So you see this cupping, and then you see this lack of ossification, and then it can result in that bone bending. So treatment for both rickets and osteomalacia would be high doses of vitamin D, lights to help convert that vitamin D, as well as for osteomalacia, especially evaluation of the patient kidneys to make sure that those kidneys are absorbing that vitamin D and other types of approaches. So gout is a disorder of the metabolism or the breakdown of purine, and purine is a component released when nucleic acids break down as part of the body's metabolism. So if that purine is not properly broken down, you can end up with elevated levels of uric acid in the bloodstream, and these elevated levels of uric acid like to go and collect in synovial joints. Especially, primarily the joint we think of with gout is that first metatarsal phalangeal joint, and those uric acid crystals settle in that joint and cause extreme pain and inflammation. Now, these will usually be accompanied by acute bouts of this that the patient will be very uncomfortable with, and then followed by, times of normalcy. Now, X-ray is not good at picking these up in early stages. By the time gout is apparent on radiography, it's usually because it's been a chronic problem. And when gout's been a chronic problem, what you see happen is those uric acids, they form uric crystals that settle into the joint, and those are called tophers, or tophi, plural. So as the tophi settle there, they can actually necrose the bone, and you can get this eaten out rat bit sort of appearance of these bones. So here's an example of a patient that's obviously had terrible long-term chronic gout. And so they would have uric acid settle into that joint space, and over time that uric acid would eventually cause necrosis of the joint space, and it can ultimately lead to ankylosing, or the joining across of the two bones across that joint space as one solid bone. Okay, finally, of our metabolic diseases, we have Paget's disease. Now, Paget's disease can take on this cotton ball type appearance of the skull. This is one I always have trouble remembering, so I try to remind myself. Paget's sounds kind of like pageants, and I think of a pageant girl getting ready for her competition with the cotton balls. And so that Paget's disease, what is actually happening here metabolically is that there's unbalanced lysis versus building. So those osteoclasts and osteoblasts are not working in tandem. So what usually happens is that the osteoclasts begin and they break down a large area of bone. And so early on in diagnosing this, you might see an area of what looks like an osteoporotic type area in the bone, and it's oftentimes in the hip bones or the skull or the femur. Now, over time, those osteoclasts then get really active, and they'll go ahead and start building up the bone, but they don't do it in the typical pattern. So they'll build them up in these little nodules. And so the balance of degeneration, regeneration of bone growth is unusual in Paget's disease, and there's no cure for this. One of the problems with this, though, is that this disease can also lead to osteosarcoma later in life. So it's important that they get a diagnosis of this so that they can watch for that transition to osteosarcoma, which would be a malignant neoplasm. Okay, take a look through these metabolic bone diseases. Make sure that you're taking note of some of the most important concepts related to each one of them. And let's go through a couple review questions. Which disease is caused by an increase in uric acid levels in the blood? That would be our C, gout. So uric acid comes from breakdown of purine, and if that doesn't occur correctly, we have elevated uric acid in the blood, and it likes to settle in the synovial joints, especially right there at the metatarsal, the first metatarsal phalangeal joint. And for our last review question, which metabolic disorder of the skeletal system is defined as an insufficient mineralization of the adult skeleton? Now we have two different types of pathologies here that can cause insufficient mineralization. One of them's Rickets, one of them's Osteomyelitis, and so the key word here is adult, and we know that Rickets affects children, Osteomyelitis affects adults, and so our selection would be A. We will continue and finish our lecture on the skeletal system next week, so have a wonderful week. We will continue and finish our lecture on the skeletal system next week, so have a wonderful week.